Welcome, everyone. It's wonderful to see people here. Some are still joining. But on a bright side, we have more attendees than panelists at the beginning of the seminar, which is always a good sign. This is the fifth seminar in our series in which we are talking about responsible AI. My thanks to my colleagues from WHO who have encouraged us to take together this very important area that is of importance to everyone. Today, we'll particularly be examining large language models. Large language models is very interesting. The architecture they're based on is called transformers, because truly what they've been doing for health has been nothing short of transformational in the last few years. Even if you look as far back as 2023, not a single RCT in health and AI was using generative AI or LLMs. In 24, we started seeing a few. By 2025, about a quarter of all modern trials in generative AI, they're all basically from this particular approach. And we have seen some wild successes. Some of you may have followed something called Therabot, which basically is a therapy chatbot already done in RCT. Patients find great satisfaction compared to humans, and it's one of the first examples of an autonomous chatbot for medical applications. The promises have been extremely high because they capture knowledge and interact with it in ways that were unprecedented. But at the same time, there have been many concerns. Almost any of you who have used it probably have found that very confidently you can get wrong answers. And health is a very critical subject. A wrong answer could be the difference between life and death. And yet, the demand is more than ever. Almost no one would say they have easy access to a high-quality doctor at the time they need. In a country like India, many other WHO SEARO countries, access to medical care, access to advice, access to even someone who can help you understand tests, results, medicines that you're already taking, even help you interpret a plan that your doctor may have provided, simply doesn't exist. And we know that when used in the right way, this can be exceedingly transformational and enabling for patients. On the other hand, this has also led to a lot of discussion regarding whether doctors will get replaced, healthcare workers will get replaced. And a lot of the discussions today, and we have some wonderful panelists today. I'll very briefly introduce them as we come along, but Professor Mayank, who will start our keynote, has been looking at this area starting from his initial stint in Delhi, now at IIT Jodhpur, on how LLMs work and how we can use them, how we can believe them, to Professor Tanmoy Chakrabarti, who has been looking from IIT Delhi on how these systems are fragile, can be broken, and how we can actually stress test them and trust, and Professor Lipika J, who has probably seen the evolution of the entire field during her time at TCS from computational language models to modern LLMs that have far more capacity, but perhaps far less understanding of how they really work. All put together, we are discussing perhaps today the most important thing in AI in medicine today. And who better to kick this off than Professor Mayank with this keynote. Mayank, I'm going to stop speaking now. The audience is really here for you, not me. So over.
Thank you, Anurag, and thanks for the team for inviting me to give a talk. Let me share my screen. Please let me know if the screen is coming up. Is my screen visible?
Yes, Mayank, perfectly. You need to enter full screen? Yes, now it's perfect. Go.
Great. So once again, thank you everyone for inviting, and thanks everyone for joining in today's talk. I know I have 15 minutes and the topic is so exciting that when I started preparing my slide deck, I was adding a lot of stuff that we have been working on. Then I realized that, if I explain everything, then I need at least an hour. So then I controlled myself and thought that I'll share some of the major ideas that we are working and with some examples and some key results that would actually probably excite all of you, and then we can take it from there. So as Professor Agrawal mentioned, that we are right now, like in the medical fraternity and the healthcare fraternity is actually now looking forward for utilizing the foundation models or LLMs for in health for helping the doctors to provide better healthcare. But before actually we reach to the stage where actually we start providing the support through LLMs, we need to actually ensure that they're mature enough so that we can build that particular trust which we put in doctors, right? So if I go and see a particular doctor, then I put a trust in the doctor, right? Means I look at how experienced the doctor is, and word of mouth and many things that actually we accumulate before actually we go and see a doctor for a particular healthcare condition. But with the LLMs, do we have that kind of trust system? With LLMs, do we have that kind of mechanisms where we can evaluate and see, yes, this is a responsible LLM that actually can help me in long run? So this is a clinical paradox. The way at least I see this is actually a clinical paradox. We are kind of, as AI researchers, we are kind of pushing or prescribing LLMs for healthcare tasks, right? Means Tanmay has been working, Lipika has been working, our group has been working a lot on developing AI algorithms and nowadays LLM approaches for different healthcare tasks. But honestly, means we do not have a mechanism to evaluate the usefulness of these LLMs for the particular task, right? Means like in healthcare, we have the FDA mechanism for drugs. We don't have some similar mechanisms in how when in prescribing LLMs when we actually go for healthcare deployments. So when I go and actually pitch myself as a foundational model researcher, generative AI researcher, and would try to convince a doctor, I would actually say, hey, means my LLM works very nicely for clinical summarization. We can do a very nice diagnostic. We can support you in your providing you faster diagnostic outputs. Even if I'm working in drug interaction, then I can actually go and tell, hey, our drug interaction approaches or our approaches for drug discovery is very, very great, right? So I can sell it from the technology point of view. However, as Professor Agrawal also mentioned, that there is always a risk of whether the models are good enough, right? And when I say good enough, it's like whether the models are going to hallucinate certain tasks. Like if we realize, or if we start depending on foundation models or LLMs on creating the dosage based on the symptoms, there is a risk that means if they start hallucinating about the dosage or with respect to the features that actually mean which may be very salient, like very small or very very features which actually trained doctors can see, but the models may not see. How actually we are going to rely if the models are missing those fine-grained features, right? And this is something that probably in the recent past we have started seeing a particular problem on fabricated citations. And the implication of fabricated citations in LLM for healthcare is that we start, like, because end of the day, what the models actually do, they read a lot of papers, right? Because we provide a lot of text material, including research papers, to these foundation models. And if these foundation models are getting trained on fabricated papers with fabricated citations, then there's a huge risk that like the models may be actually taking certain decisions which probably do not exist, like which we can't rely on, right? So they may actually have certain biases that we actually push in the training corpus, which actually hurts the overall progress in this particular direction. And as I said, like since there is no FDA equivalent approach or the mechanism, we don't have a systematic framework for auditing these clinical LLMs for their faithfulness, for their data provenance, and including like privacy aspects, like this, if the data that models are using to uh, train the systems or train the model, whether they are privacy protecting or not, right? And if a user tomorrow says that please don't use my data for training purposes, how can we remove that particular information using some unlearning mechanisms, right? So there's a lot of actually gap that is going on, and I'll highlight two of the gaps with our experiences in our research. But before actually I go, this is what the pitch is, and probably this is my initial slide as well as the last slide, where actually we are trying to pose a question. The real question is not about the capabilities of LLM. Means Tanmay will create an awesome LLM, but whether this LLM is going to be trustworthy in terms of clinical stakes, right? Will you trust? Will I trust? Will Tanmay himself trust this LLM for his own kid? Like and go and actually trust completely on this particular LLM. Sorry, Tanmay, I'm picking your name, but then since you are an expert in LLM, I'm just like taking to the level where we need to build that particular trust model where the systems can actually help doctors to make certain decisions and help in a positive way rather than actually creating any harm. And for that, we need actually four pillars in reliable data, reliable reasoning, reliable inclusion, and reliable corrections. These four pillars are very important, at least in my opinion, when if you have to take the LLM research to a clinical LLM level. And as I said, like I'll pick two examples which can actually make the case of why I would like to highlight these four important pillars. So during COVID, when we were working on how actually we detect COVID, particular X-ray, whether the person is actually developing the symptoms of COVID or not, we actually were flooded with many systems. And almost every system was claiming 99% accuracy. And Professor Agarwal was in the loop in all those discussions, and he knows this particular scenario when everyone was claiming 99% accuracy. And when we started testing those systems or the algorithms in the field for India, the accuracies were even actually not the best performance we got was about 45%, 48%, not even 50%. And the reason was actually something very different altogether. Like as a AI researcher, we would never actually think from that perspective. But as a clinical, as a doctor, that would be the very first thing that actually you would look at. And here is a particular chest X-ray that I'm actually highlighting over here. If you look at this particular chest X-ray, it's a COVID positive patient. But when we actually ran many of these algorithms in those days, like in early days of COVID, all the algorithms were focusing on an area which had nothing to do with COVID. And they were actually focusing on if you look at on a right-hand side on top of the X-ray, you see a certain blob sitting over there. That blob is nothing but a pacemaker. So the algorithm was actually focusing on that particular pacemaker. All the algorithms were actually putting the emphasis on the particular pacemaker. All the all the activation maps were actually focusing on that, and it became kind of a correlation as if like if you have pacemaker, then you have COVID. So algorithms were actually behaving like if they see a pacemaker, then this means that you have a COVID. And when actually we were testing these systems in India, and the reason actually why we had a lot of pacemakers, because the data was coming from European countries, like Italy particularly, they had released a lot of training data, like for 2,000 plus X-rays of the COVID patients to help the community to build algorithms faster. And when the models were trained on that particular data, and remember in Italy in the first wave of COVID, most of the patients were 70 plus, and many of them had actually pacemakers. Now the algorithms were picking that particular cue that if you have pacemaker, you have COVID. In India, at least when we started trying in India the major age bracket was about 40 to 50 years, right? And generally people with age 40 to 50 do not have pacemakers. So for them, because there was no pacemaker, they all were healthy, and that was a huge problem, right? So the models were not actually explainable in the sense that they were not looking at the COVID symptoms. We further analyzed like what was happening, and we realized that while in most of the training corpora we had a lot of non-COVID cases, because all the training people were doing is like combining different samples. And COVID samples were very few in this particular TSNA graph. You would see the COVID samples were very few, whereas all the red dots are actually the non-COVID. And using this particular training data to train for a COVID algorithm was actually a humongous task. And very recently, this is a paper which is still under review, but I thought for this particular talk, this is a very good example to highlight. Recently, we started actually working on this particular VLMs to give them a particular sample and ask a particular question as if a doctor is actually providing a note. Now, we wanted to understand if these models like Blip, Quen, including the recent Quen 3's VL 8 billion model, whether they understand these kinds of notes or not. What we realize is that if the doctors are writing everything in affirmation, then the models are understanding it pretty nicely. But the moment actually doctors provide any symptoms or any observations in a negation format, right? Like for example, look at the second example, cannot be excluded as not being neoplastic. So it's a triple negation, which means it's actually possibly neoplastic. But for the models, it was coming out to be no neoplastic. Now, if I'm actually relying on a LLM like Quen to actually do the analysis, then they would actually completely go wrong. Right? So we have actually shown this that the pure negation failure in the recent Quen model itself is more than 11%. And remember, negation is just one of the compositionality. There are many compositionality factors which come into the picture. Just by negation itself, we are actually causing 10% error in a recent model like Quen. And as Professor Agrawal again said that even a 1% error is going to be a major error. And here we are talking about 1%, even Quen 2.5 billion had like 25% error. And it's not that the buck is stopping at these Quen models, even GPT, Grok, and SDXLs. In the generative sense, they are also actually running way behind. Like in this particular evaluation, we tried with about 500 prompts, 480 prompts, and one being the highest score. Models were barely reaching like 50, 55%, 60% of the overall performance metric. Right? So negation just as a one compositionality is a huge error, a huge problem, which we have to solve it if we have to include this in a context to medical and healthcare. And as I said, like the four pillars are essentially then therefore the way I would actually portray it, that data integrity, if we do not get the correct way of providing the data to the model, if the data is garbage, so it's like garbage in, danger out for healthcare, right? It's not garbage in, garbage out anymore. For healthcare, I would actually portray it as a garbage in, danger out. Compositionality is like the way I mentioned, negation is one of those, but there are many such actually compositionality issues that actually take the problem to the next level. With India, I think we should also be taking care of the cultural nuances, particularly with respect to the linguistic issues which may actually feed into generative biases. Right? So if you're going to use foundation models, LLMs, and generative systems, then we need to be taking care of different linguistic and cultural nuances, which India poses a very unique opportunity for all of us. And my own research actually these days focusing on machine unlearning for providing the safety net or the safety walls with respect to the privacy for these particular LLMs. And towards the end, I also just wanted to highlight one of the major problems, because generally we spend a lot of time in building models, but we don't actually worry about the data sets. We assume that the data sets are pretty good, and therefore we just like blindly adopt any of the data sets. In our Nature Machine Intelligence paper, we audited many data sets, like 60 plus data sets belonging to biometrics and healthcare community. And what we realize is that, since the interest of time, I'll quickly go to this slide. What we realize is that none of the data sets we actually audited, as I said, like 60 plus data sets, none of the data sets were actually following all three verticals like bias, privacy, and regulatory compliance to its fullest extent. None of them were actually ideal data set to say that yes, it is privacy sensitive, it is fair, and it actually complies to all the regulatory compliances, including right to be forgotten. And that was a huge surprise for us, that like given that the medical community values a lot on data integrity, the medical data sets, that 10 plus medical data sets that we used in our evaluation, none of them actually could score more than even 50%. We also observed a privacy and fairness paradox, that if you increase privacy, then you will lose fairness, and if you increase fairness, then you will actually lose privacy in orthogonal fashion. This actually opens up our eyes in terms of that, data integrity is a huge challenge when we talk about building the foundation models for the future, right? So with that, I think my 15 minutes time is up. And the closing message that I would actually like to say is that AI should be a stethoscope, not a black box, when we talk about LLMs for healthcare. With that, thank you very much.
Thank you very much, Mayank. That is a wonderful discussion of both the promises and the perils of AI. And I think that's a very important view for all of us to take. From here, we'll move to the panel discussion. And of course, I've already briefly introduced the speakers. And we will probably ask you the first question, Mayank, to get us rolling, because it'll be a continuation of where we were. So, we keep speaking about trustworthy performance, and you indicated very clearly in the beginning that the regulators haven't quite caught up. Now, the reality of the world is that we are going to keep rolling forward. So, to your mind, given all the limitations that you discussed, given all the concerns at this point, as we stand, given that trials are going to happen, ethical approvals will take place, what does trustworthy performance mean to you for LLMs in healthcare? And in case current benchmarks are not sufficient, how do you see the benchmarks evolving? Over to you.
I think this is very important, and as I mentioned, there is like a lot of effort going on in building the LLMs and foundation models for medical fraternity, and there are quite a few actually existing benchmarks are there. For example, MedQA and PubMed QA, these kinds of evaluation protocols and benchmarks are getting developed, and they test actually whether the model gets the right answer on medical knowledge questions, right? And then LLMs are actually performing very nicely in many of these evaluation benchmarks, right? And like one of the recent models I remember, MedPalm 2, if I remember the name correctly, that has actually crossed the expert level thresholds, and many papers also claim that means their model actually is doing better than radiologist or ophthalmologist, right? But this is the easiest dimension to measure in terms of clinical accuracy. The more actually problem comes in with respect to when we talk about testing these models to a more complex settings like compositional faithfulness that I talked about. The questions like, can the model handle the logic of clinical reasoning? Right. So extending the current benchmarks to the level where actually we can talk about that the models are actually able to reach to the clinical reasoning level or not, right? And our work that we recently presented in AAA also, where we talked about this compositionality like negation, quantification, the conditional reasonings. All these are still actually an open question for these benchmarks as well, right? Because the benchmarks do not incorporate many of these aspects, right? So another issue that in compositionality we face is counting, and many of these histopathology cases, many of these X-rays where we count the let's say in histopathology we count the cells, right? What is the error rate in of these algorithms when we actually do a lot of counting, right? So how to test the compositionality logic under clinical conditions? This is where actually we need to worry about, and the benchmarks do not take, like MedQA does not have a negation stress test. So it's a massive gap. We have to still develop it. The third point actually is on this particular is that again, like the point I made with respect to the Indian context, right? It's about equitable performance across population and language for us. We have 22 scheduled languages. We have a population varying from top to bottom, like from north, south, everywhere. Like the population varies, the language varies, and the context also varies, right? So how do we actually say that these models which are English centric, 95% of the models are English centric, right? So if we score 95% on English centric data set, what does that mean to actually say that what is the model performance on a Tamil speaking or Kannada speaking scenarios, right? So how to actually take this particular generative foundation model LLM kind of settings to population and languages? And finally, actually, I would also like to say that the temporal reliability with respect to the long-term evaluations, a patient comes over a period of longer time. How these models behave, we don't know. Means no benchmark has been actually developed to uh, ensure that actually this temporal understanding is better evaluated. Right? So therefore, in my opinion, the benchmarks, that current benchmarks are there, they are okay, but they are dangerously insufficient. That is what my take is. And a lot of work has to be done, and India can take lead on this actually.
Thank you very much. I mean, that points out very nicely that accuracy is not safety, and particularly accuracy on a benchmark that is not equivalent to the real task that the LLM would be used for is clearly not the right benchmark. And India needs to do a lot of work simply on figuring out how a country with so many languages, so many clinical contexts, so many other things gets its benchmarks right. But be that as it may, Tanma, I'm going to come to you next. The reality is, even the top performing on a benchmark, 90% plus accuracy, given that it is LLMs, given it is transformers, given it is about coherence, will sometimes go surprisingly wrong. And it seems to almost be built into the architecture that risks will be there. So knowing that something has performed well does not mean there will be no risks. So we also have to look at from the point of view, how do we at least minimize those risks, mitigate those risks? And that's something that you do. And over to you for your thoughts on going beyond standard benchmarks to actual risk mitigation plans for these kind of models.
Yeah, thank you. Thank you, Dr. Anurag. So before I start, I should mention that, if you look at the human clinical decision making, right, we already have been tolerating high error rates in human clinical decision making. If you
True,
look at
very
the
true.
right, so if you look at the US statistics, right, diagnostic error. I was reading some news articles today. Diagnostic error affects an estimated 12 million Americans annually, right? So the question, so that we should not ask this question that is LLM, is AI perfect or not, right? We should ask the question that is AI better than counterfactual, or for whom? Right? That's the type of question we should ask. And the primary reason that we tend to believe that AI is LLM is highly accurate is the way LLMs produce fluent responses, coherent responses, and the great ability to synthesize vast knowledge. That's the beauty of LLM, right? Now, of course, like every AI model, these LLMs are also prone to errors and so on and so forth. So I therefore always believe that when it comes to deploying LLMs in medical setup, we should, I mean, I don't think
I think an AI knew that you got to something bad and froze you, Tanmay. Well, amongst many possible poses to be caught on, Tanmay has been caught in a very nice thinking pose while we wait for him to come back. And I'm sure he will. Maybe Lipika, to not waste time, I'll jump over to you and basically ask you to perhaps continue along the line of thought that we were discussing. Given these problems, how do we best get the value out of LLMs? And then we'll get back to Tanmay after he comes back.
So thank you, Anurag, for first of all organizing this and having me here. And Tanmay actually stole my opening line, where I was ready with a news article that was published in Economic Times on March 19th about this is from insurance sector, but where they have actually printed that how many times insurance claims actually get rejected due to errors in creeping into the discharge summaries, which are prepared by humans at the hospitals, or because of doctors noting down initial symptoms wrongly, and therefore it all compiles into actually insurance claims getting rejected. Say, for example, the patient mentioned condition has been lasting for 2 years, whereas the doctor noted it as 6 years. Or sometimes it was like, things like a doctor mentioned possible possible disease. That's what exactly is mentioned initially. After that, due to tests, etc., it might have been eliminated, but in the discharge summary, for some reason, some human puts it as that disease as a pre-existing disease. Now, all these are human errors, and that these are documented and that have led to real issues in real life with this is from insurance studies, but I'm sure what Tanmay was saying is there are many of such cases where there are misdiagnosis errors and so on. So the first thing is, and even Google had one of the early studies where they had been working on eye data, which is say to predict 5 years down the line whether a person would have glaucoma or not. And they found that the system was much better than actual human doctors. And more than that, it was that the human doctors also disagreed among them much more when it came to a prediction. Say 1 out of 5 doctors said yes. Now, still, those 4 doctors are practicing, and the error limits may not be same for all the examples. So, Tanmay's point that indeed this is an area where a lot of outputs, human-generated outputs, are also, if we interpret it, they are quite probabilistic in nature. Now, coming to that, what essentially, whether it is LLM output or generative output, let us see what is the nature of the output. They are probabilistic in nature. At any given point, the outputs are probabilistic in nature. The problem is that when we look at output from a computer system, our traditional interpretation kind of makes us believe that it's a number, it's infallible, it's going to be forever the same. That's how we have always interpreted computer output, though we have not interpreted human outputs like that. Okay, even going back to the same doctor with more information may give a different picture, may elicit a different picture. There may be medical board sitting and coming up with a different picture and so on. The problem, therefore, one of the things that governance structures are looking at is how to make the outputs appear as they truly are. They are probabilistic in nature. We currently are serving them in the same framework as we serve deterministic outputs, and that's not a right thing. Having said that, say for example, you yourself gave a lot of examples where they are doing quite well. Let's say summarizing, and I'm pretty sure even my own doctor, I have proofs to understand that the doctor is using a summarizer. Now, obviously, that's the human in the loop or a co-pilot approach, where the doctor is after that applying his or her own mind over it. So this is acting more like a second set of eyes for the doctor, and that's a very good application, I would say. Along with that, having been in the industry, I have realized that the best of software, ultimately, the success of the best of software also depends on the human interface through which it is using. Current general purpose LLMs spewing huge set of tokens for every question is not the best thing to be served to a doctor, or not even when the doctor is busy. They can't read, so maybe they are reading a little bit of it. And also, for the patient or for the nurse or for whoever it is suggesting the monitoring steps or the possible, when a doctor is writing, it can suggest possible drug interactions. Now, that's a very good application to be deployed at the back end. Now, but to be served in such a capsuled way so that the doctor can immediately be aware, but not necessarily spend minutes on it to go through it, understand, and then apply it. So I think one of the key things right now that we are not yet there is how do we serve the information in a particular way, in a very personalized way, in a customized way to the different sectors, and also with plausible wherever that backup. So, in many cases, we are already aware of it, that there are, post-processing techniques, all this bias and fairness, they are already applying a lot of post-processing techniques. Medical world has protocols, has knowledge graphs which are fairly standardized. So a lot of these are actually coming in to work on top of the LLM outputs to make them safer. That's all I would like to say.
No, that's a very good point. I'm going to promote myself to a panelist in absence of Tanmoy. So I think, Dr. Dev, I mean, your point about post-processing the output of an LLM to ensure that the answers don't become too scarily wrong is a very good point. And Mayank, in point of your counterfactuals, I think there are two good questions to ask always. If no answer was forthcoming, like for example, there is no healthcare, how bad would it be? And if a wrong answer came from the AI, forget LLM, how bad would it be? There are many situations, particularly on screening systems, where ultimately if something said yes, it will go towards further checking by somebody else before anything irreversible is done to the patient. But if nothing was done, the person could slip through the cracks. I mean, take the diagnosis of hypertension. If
Dr.
nobody
Anurag,
ever checks your BP.
can you hear me now?
Tanmoy, welcome back. Yeah, welcome
Yeah,
back.
I'm
I'll
so
just
sorry.
pass
I'm
over to you.
connecting a very weak Wi-Fi zone. But sorry, please go ahead. Sorry,
No,
extremely sorry.
No. So, for example, screening of a disease like hypertension, which is a silent killer. If nobody screens you for hypertension, that's very bad. If somebody with an unreliable BP machine that tends to overestimate blood pressure and say hypertension incorrectly from time to time, but then you end up going to a doctor with a proper BP machine, one can live with it. It is still better than nobody checking your blood pressure at all. So I think one must frame many of the ways in which we use AI in the clinical context of the cost of not getting it done and the cost of being wrong. And wherever things are reversible and errors can be controlled for post-processing, post-clinical systems, we really must use AI as opposed to being afraid. And the Indian AI strategy was very good that way, with risk calibrated governance, promoting innovation. And these are wonderful things. Now, Tanmoy, back to you. Since we have you back, you can complete the point that you were making regarding how do we mitigate the
Yeah,
risks. And just to
yeah.
fill you in, Dr. Lipika Day already spoke about post-processing, knowledge
Mm-hmm.
graphs, and things like
Mm-hmm.
that help reduce the error.
Yeah. So what I was actually saying is that LLMs, like all other human beings, right? Now LLMs are AI models, right? They are prone to error. So I think at this moment, at the current stage of the LLMs, what we have, I think we should basically think of AI LLMs as should be deployed to do a low risk task. For example, tasks like summarization, documentation support, right? Patient education, drafting, and different administrative supports, treatment recommendation without supervision, and so on. But I think when it comes to actual mitigation, right? There are multiple ways. I think Professor Lipika already mentioned about many things. I missed out those points, but I just wanted to point out some of the strategies that people generally use, irrespective of whether it is medical AI or not. People look at two sides of it. One is more from input side production, right? So specifically, you look at detection and blocking of prompt injection, or let's say some attempts to override safeguard, right? You flag high risk queries and so on and so forth, right? From model side safeguard, we should also look at more of a grounded response generation. I think it was already mentioned that methods like RAG, clinical guidelines based responses, calibration, uncertainty estimation, right? These are very standard things that people use in LLMs, right? And then you'll also look at output monitoring, more of an auditing kind of stuff, right? Looking at, let's say, regularly monitoring the logs and audit trails, right? You'll also look at unsafe outputs and post-process your models based on unsafe outputs. There is something called reinforcement learning from human feedback. So you look at the outputs which are generated by models which are not safe, and you again further fine tune or maybe write some interesting rules, right? Some sort of neurosymbolic AI based rules to not let the model produce similar kind of unsafe outputs in the future, right? Similarly, you can also think of some sort of continuous rate trimming, red teaming, I think people are aware of this term. This is basically understanding different vulnerabilities, gaps in LLMs, right? So continuous stress test systems with adversarial scenarios. You also need to look at cultural and linguistic context. For example, Mayank mentioned about, right, Indian context, right? And I think continuous red trimming is very important. So three important things: input side protection, output side protection, and model side safeguard, and then continuous monitoring through different types of attacks and different strategies and so on.
Thanks, Tanmay. In fact, when you said about stress testing, it reminded me of one of the best doctors I ever knew. Once, while preparing a patient for cath and a line insertion, he was doing it with his left hand. And I was asking, why are you doing it with your left hand? He says, because in emergencies, you never know on which side of the bed you are and, which hand you're going to have to use as a dominant hand, not to reach across if a surgeon is working at the same time. So he was preparing in advance for situations that might come in the middle of an emergency, multiple people working on a trauma patient, so he can work equally well with either hand, whichever is closer to the side of the patient. So, I think it's a very good thing. And I think we should think of AI safety in the same way. You have to stress test it with difficult and look at the tails, not only the center, because in the end, the tails is where things break.
Absolutely.
One question to each of you, since this came up. Many people seem to think of AI as a place like a doctor. The AI doctor is the most interesting thing in health for them. But I think, Lipika, you said something I completely agree with. The tasks where AI will probably be most useful immediately are like workflow optimization, summarization, boring things that anyway doctors don't want to do. They'll be happy to AI do it for them. And the cost of being wrong is relatively small. Mayank, what are your thoughts on what are the best applications to start with for AI currently, what it is ready for? And you can take both narrow AI and broad AI. While the topic is LLMs, we don't have to, for this answer, be constrained.
One is certainly summarization is where generally what happens, like I was taking my mother for particular to a particular doctor, we had to wait for half an hour for the medical summary. If the AI was to be there, means probably in 5 minutes I could get the summary and then I would be out of the hospital. So this is where means AI is certainly useful and probably mature enough for this kind of task. Second is with respect to because I work in the broad domain of vision and language understanding, the intersection between the two. I believe a well-crafted system which understands, let's say, the radiology data, the 3D voxels, and all this information that is available there. While I would not say that completely rely on it, but actually they can be very good assistants to the doctors, to the radiologist, because they can pick up nice, minute points if they're well trained. Right. And the doctors can actually then build on top of it, correct on top of it, and quickly reach to a particular decision. Rather than actually saying that completely rely on this, as of today, I won't actually rely. I won't actually bet my loved one's health on a complete AI system, like completely autonomous AI system. Rather, actually, a doctor supervising or an AI assisted doctor who can actually provide me the. So those things are still actually happening. Histopathology, these kinds of things are very mature in terms of, even as you said, like narrow AI. The counting with non-LLM algorithms is much secure, much higher than actually LLM-based algorithms. Right? So
no, wonderful examples are there. For example, for colonoscopies and adenoma detection. It is a boring task to go through feet and feet of colon looking for potential polyps. And multiple studies show that this is where computer vision, narrow AI, trained specifically for those things, really makes the human operator better. Same things for chest X-rays, many other things.
One of our research jointly with AIMS Rishikesh is on understanding the plaque burden based on IVUS data. So they put the sensor inside and then using stent, and then they figure out the overall plaque burden. They capture a lot of photographs. It's a very only a very specialized doctor can actually do this whole job. right? But then if the AI is there and then we have, let's say, 2,000 slices of this entire area, right? A doctor has to sit down and look at 2,000 slices is impossible. But an AI algorithm can do it much faster way. And it's there.
So I think the consensus we are getting is LLMs for tasks where the cost of error will be small and burden of capturing large amount of information, particularly text information, is high. And other applications, doctor's assistants, very well trained narrow AI systems that can do tasks that are even superhuman at various levels. So we're going to start opening this up to the audience. I think, Tanmoy, the first question is perhaps right for you. Ashish Tiwari is asking, what type of adversarial attacks we should test the model systems who are built for healthcare? Any data set prompts available to test the healthcare AI, Gen AI, chatbots, and things. So Tanmay, I'm going to pass this one to you because this is your area.
So adversarial attacks can be of different types, right? For example, it can be a black box attack, it can be a white box attack. So when it is a black box attack, the idea is that you do not have access to the model parameters. So what you do, you basically play with the prompts and you try to attack the model so that the models produce something which is not intended, right? In case of white box attacks, you have access to model parameters, and then you can do multiple things. White box attacks are very rare. I mean, because of the fact that most of the models are black box, you basically need to play with the prompts, right? Now it comes to how to write prompts. Now, by the way, there are multiple benchmark data sets available to understand attacks, but again, you need to remember the context for which task you are interested in attacking the model. Let's say, for example, one of the applications that I focus on is mental health. Let's say chatbot or any decision-making systems related to mental health. What people do is that people write prompts in such a way. Let's say it's a dialogue system, right? Let's say you deploy interacts with a patient, right? Now you attack the model in such a way that the co-therapist starts asking questions which are not intended. For example, you ask very sensitive questions, let's say related to the family, right? Related to your caste or religion, right? Which the patient is not at all comfortable with, right? So now again, there are two different ways of writing such kind of prompts for attacks. One is you write hard prompts, you write prompts in English, and you attack the model. And other is soft prompts, where you do not, you do not write the write prompts in natural languages. There is a module which will convert your prompt into some sort of embeddings, and that embedding will be fed to the model for further processing, right? Let's say chatbot. So in case of chatbot, the example that I gave, you manipulate your prompts in such a way that the model start failing, right? For example, there can also be cases where you also try to write the prompt in such a way that the model produces wrong distribution. By the way, I think somebody was mentioning about, I think Mayank was mentioning about the capability of a model to produce numbers, counts, right? Distributions. I mean, if you look at the existing models, even great models like Gemini, GPT-5, these models are extremely bad in producing distribution, right? Let's say you have a corpus, and you ask, tell me what's the percentage of people who said positive about this factor or negative about this factor, and you see such a simple distribution, the model fails tremendously, right? And this can be one portion, one aspect which you want to attack, because you know that these are the parts that the model already are dumb, right? In terms of responding things. So you start attacking on that point, and you see some sort of failure happens. So as I mentioned, so in short, there are multiple ways to attack the model: white box, black box. Within black box, within white box, there are natural language attack. There is attack called soft injection, soft pump injection, and so on and so forth. And there are data sets available, but again, these data sets are very generic. For your context, for your task, these data sets may not be applicable.
Thank you. And as you were speaking, I was thinking to myself that we should not be giving ideas to people, but that's absolutely fine. I'm sure that's not our audience today. There are interesting questions, and I'm going to get to first of them to Mayank. I'll go to you. That you had already said that hallucination is sort of inbuilt in the LLM models, right? And Dr. Day, you had made a point about doctors disagreeing with LLM, this inherent in the way doctors are trained. When we see differences between LLMs and doctors, how do we look at this? So, for example, we could set our LLMs or AI, we can even use AI here in place of LLM, to be conservative and err on the side of being beneficial to the patient, such that it may take a very experienced doctor to look at an abnormal eye disc and say with confidence there is no glaucoma. But we might want to train the model to perhaps overestimate the word glaucoma check to be done simply because we don't want to miss a silent killer. Is that how you see this correct way to program these things, even at the cost of accuracy?
So see, the thing is, the end of the day, if I look at our classical book on pattern recognition by Duda, Hart, and Stokes, end of the day, all these problems are boiling down to false accepts and false rejects, right? Even in healthcare, also, end of the day, this is all what we are talking about. And the real question here isn't about like can LLM diagnose or not. I believe the real question is that who validates these LLMs, and do they have the experience to actually catch when LLMs are confidently wrong, right? So like again, like I'll take the example, the point from my false positive, false negative thing, is that if we have a false positive for glaucoma, this means unnecessary treatment, like doctors will start treating a particular patient if we have a false positive. That will also increase like the load on the system, on the healthcare system. At the same time, the risk is with respect to false negative means that if I have glaucoma and doctor has missed it or LLM has missed it, then this means that I may go blind. It's, and both are actually very dangerous. And as of today, the models do not have understanding of about this particular asymmetry, and therefore still like I would give more weightage to the doctor's judgment. At the same time, I would also like point out that even if there are like four doctors and four doctors can disagree, right? So among themselves or with LLM, so treat LLM as a fifth doctor. So we should, when we do that, like when let's say I go and take my loved ones to doctors, and if I don't understand the reasoning of a particular doctor, what do? I go to the next doctor, right? I talk to 3-4 doctors if there is something serious, and then I figure out like who's right with respect to the reasoning, like who is reasoning and who is doing that particular analysis and convincing me. So that is probably the spectrum that I think we should look at in terms of saying that the LLM is right or wrong, or whether the doctor is certifying this right or wrong. When the doctor should also actually look at the reasoning of LLMs before actually they make a particular judgment about disagreeing or not disagreeing. But end of the day means I would actually go with the doctor's judgment, be it assisted by LLM or not, or agreed with LLM or not.
No, I think that's very true. And doctors are possibly the best placed people to decide which side to err on. If you're going to have to err, more false positives or more false negatives, and that's a very clinical decision regarding the consequences. If you think going blind is, of course, a much bigger risk than perhaps something else, especially if your healthcare system is not stressed, you could go in one direction. Lipika, there is a question that is perfectly aligned to one of the areas that you always bring up. It is important to have regional, local, relevant data to train AI models. And AI models trained on data dissimilar to the system in which they would be used will be wrong much more often. So, are there good examples that you are seeing either at the corporate level within India or outside India is also fine? This is a WHO SEARO webinar. Outside India is absolutely fine. We know the West is doing it. But within India or in the SEARO region, are you seeing good efforts to create local models with local data within the country private or public? Are you seeing that happen?
Of course, I mean, we already have the server models which are trained on Indian data out. As of today, I have not done a lot of clinical data testing, but I would like to say that the error levels are really very, very high, even with very generic questions. I have tried that. So definitely, but the language is fluent. So the model ensures that the same way they have been trained on whatever, the same transformer model. So therefore, the fluency part is fine, but the error levels are surprisingly high in today's server models as compared to the Gemini model, even on very, very local data. Like I asked about Bengali literatures, and I gave the question in Bengali, English, etc., and I got very wrong answers with server. So definitely, the data part is not good. The language part is there, but data now today, all these models have tremendous amount of data that is available to them. Now, let me answer this question in a slightly different way, also related to somewhat stress testing. Tanmay explained stress testing in a very, logical way and the theoretical way that goes on. Let us go back a few years to translation as a problem. Okay, machine translation, and let us see what Google, Facebook did. They just made it open for people to try, and then entertain themselves with the translations, and look at where translation is today. So of course, when they first opened it, they were masked language models, and today they are large language models. So there is a difference in the thing. But where did they get the data to train it from? They actually got the data, the feedback, what all kinds of errors are happening from the way people were using them. Okay, coming back to your question of stress testing, or for that matter, we don't, so certain things are good today, like a co-pilot for a physician, and if we have the way to use them, they are maybe quite ready. Certain classification systems, not large language models, not generative models, say classification systems, if they are good, if also explanation is built in, let us say. The question is, we are working with models which were trained with data from elsewhere or whatever, or even when our clinicians are trying to reproduce them, there's no data. Okay, and we have privacy, etc., in place. Now, why not we have all the hospitals at risk? I'm not saying they make it public, etc., but if they take it upon them to use their own data, whatever they are gathering from the people, and putting it back to these AI systems, and they, at the end of the day, they have their own clinicians diagnosis, outputs, whatever, to validate. So it is not for the purpose of using right now, may not be, but at least from a guidance point of view, that is the only way when we can generate data. Otherwise, how will we ever generate data and even configure it for our own use or whatever? Every time we cannot start from scratch after we have decided to produce a model. So what I feel right now, even if we are not at the level of applying it for Indian context, we have to start looking at it 5 years down the line. We should start capturing all different kinds of data. Our country's particular problem would be that many people cannot type, so they would be possibly speaking, and that's where Sarvam also started looking at audio data. And that way we will also start gathering all the variations that clinicians have. Whatever even Mayank was mentioning, this triple negation or whatever was not something that you observe in generic data, but you observe them a lot in clinicians' data. Perfect. But we need real data to have these real examples. So if we have to start today, we should start at data gathering and trying to see how our models build models based on our own data. I think that's a very important task which we all should take up.
Perfect ending for today. LLMs became possible because of massive amounts of data they were trained on. Their capabilities came from this massive amount of data and compute, of course. That's the other side. There is no path in which India becomes strong at all this without creating a good data ecosystem. And that indeed is one of the pillars that the strategy for AI in healthcare for India very clearly identified, that a good quality data ecosystem for India is absolutely necessary. These LLMs, to train them, are data hungry monsters. Even tuning them requires at least sufficient diverse data. And for all those of you, listening today, who are in ecosystems where medical data gets produced, please see that how we can try production of data to capture and use of data. Otherwise, once it's produced and lost, it's as good as if it never existed. Thank you all so much. It was a wonderful chat. Thanks to the panelists. Thanks to our keynote speaker. Thanks to the organizers, WHO SEARO, IntelliHealth. I mean, it's been an absolute pleasure to work with you all. I look forward to seeing you again. Same first Wednesday next month all over. Thank you.
Thank you,
Thank
everyone.
you.
Thank you very much.